Good morning, remote attendees. Doing a sound check. Brian Alston, can you hear me?
Yes, Dan.
Excellent. Thank you very much.
I'd like to call the meeting of the board to order. Will the secretary please call the roll?
Director Bott,
Present.
Director Burnett Ziegler, Director Garza is absent. Director Green, present. Director Harrington,
Present.
Director Kim, present. Director Lowry is absent. Director Ryder,
Raiders here.
Director Robinson,
Present.
Director Sorrell, present. Director Webster Cross,
Present.
and Chair Taylor.
Present.
You have a quorum.
Thank you. I'd like to entertain a motion to allow Directors Bott and Webster Cross to remotely participate in this meeting as voting members. So moved. Second. Thank you. The motion has been made and seconded. Is there any discussion on the motion? All in favor? Aye. All opposed? Thank you. The ayes have it. The motion carries. The first item on today's agenda is employee recognition, which will be reviewed by Director. Are you? Wow.
Yeah.
All right. By Dr. McGuinness. Thank you.
All right. Thank you, Chair Taylor. Good morning, directors.
Good morning. There you go.
Here we go. We'll start, as always, with our new hires. We'll start by welcoming Rasa Kozlowskaite, Medical Director of Endocrinology, Siona John, Chair of Division of Neuroclinic, Neurology Clinical, John Listina, House Administrator, Nursing Administration, Rashika Whitaker, Surgical Nurse, Navigator, Ophthalmology, Ricky Hem, Clinical Operations, Nurse Supervisor, Medical Surgical, and Philip Scott Montgomery, HR Business Partner, Human Resources. And congratulations to Michael Bednarz, Chief Psychiatrist, Correctional Health, Mental Health Services. And we have some recognitions and announcements, celebrations. If the team is in the room, please stand so we can recognize you. First, I don't think she's going to be here, but we have
Is she in the room?
Our first baby of 2025. Welcome to the world, Astrid Sophia. She was born on January 1st at 8:53 at Stroger. Sticking with birthdays, we are excited to announce a new initiative, the Birthday Health Screening Program. We're encouraging Cook County residents to give themselves the gift of health during their birthday and schedule a prostate cancer or breast cancer screening exam. CCH launched the Birthday Health Screening Program this month, thanks to the support of CCH Board Vice Chair Commissioner Bill Lowry. Congratulations to the Cook County Health physicians who were named to Chicago Magazine's Top Doc list. This includes almost 1,400 area physicians nominated by their peers as best across various specialties. Congratulations to Dr. Welbel in infectious disease, Drs. Giovingo and Thompson in ophthalmology, Dr. Marcus in surgical oncology, and Dr. Margetta in cardiovascular disease. Congratulations.
Well done.
Congrats as well to Craig Williams. Here. He's Cook County Health Chief Administrative Officer, being recognized by Becker's Health on their list of COOs to know. This list includes leaders who expand service lines, foster employee engagement, and spearhead transformative organizational improvements. Congrats, Craig.
Congrats, Craig. I think I know Craig.
I've met him, yeah. Congrats as well to Angela O'Banion, Cook County Health Chief Information Officer, for being selected as one of the Chicago Defenders 2025 Women of Excellence. The Chicago Defender Women of Excellence Award celebrates African-American women in our community who inspire others through dedication, accomplishments, visionary leadership, and positive influence. Congratulations, Angela.
Well done, Angela.
Congratulations as well to Dr. Rami Dukey. I saw him here earlier. There he is. He's Cook County Health Medical Director for Cardiovascular Service Line. He was named to the American Society of Nuclear Cardiology's Executive Council for 2025 and will serve as the Secretary of the Council. Congratulations.
Congratulations.
Congratulations to Maeve Dixon, Director of Projects and Strategic Initiatives, Health Plan Services, for being selected to join the 2025 Leadership Academy for the Association of Community Affiliated Plans. ACAP's Leadership Academy is a one-year program that empowers up-and-coming health plan staff on important issues related to Medicaid managed care programs. Congratulations, Maeve.
Congratulations, Maeve.
And congratulations to Deanna Durica, Director of Public Health Policy for CCDPH. She was selected to be a part of the 2025 cohort of the Civic Leadership Academy, the CLA, at University of Chicago Center for Effective Government. The CLA is an interdisciplinary leadership development program for emerging leaders in nonprofit organizations and local government agencies. Congrats, Deanna.
Congrats.
Cook County Health had clinicians lead a discussion on winter safety in late December with the Cook County Office of Emergency Management and Regional Security. Panelists shared tips to avoid cold weather injuries and resources available to residents. The event earned more than 30,000 impressions on social media, and a big thank you to Doctors Umakant Avula, Stathis Pulakidis, Kate Hedlund, Deanna Jackson, Angelica Moore, Bobby Pollard, Laura Kozak, and our partners at EMERS for a successful and insightful event. Thank you.
Well done. Thank you.
Congratulations to Dr. Eric Makaitis, Cook County Health Chief Executive Officer, for being included by Crain's Chicago on their list of Who's Who in Chicago Business 2025. This year's edition features more than 450 influential leaders who are shaping Chicago's business, civic, and cultural spaces. Congratulations.
Thanks, Wayne.
And that concludes the first part of the report. Chair Taylor.
Thank you very much, Dr. Makaitis and Wayne. The next item today is public testimony. As a reminder, written testimony will not be read into the record, but will be included in the official record of this meeting and posted to the website. Madam Secretary, do we have any speakers who have registered to provide in-person or virtual oral testimony and submitted written testimony?
We have 4 speakers who registered to give in-person testimony. The first person is Susan Avila.
Perfect, thank you. Welcome, Ms. Avila.
And as a reminder, you have 3 minutes. I'll give you a heads up when you have a minute left and then when your time has expired.
Okay, thank you. Good morning.
Good morning.
Good morning, everybody. Today, I am speaking as a retired health system nurse and leadership of the Collaborative for Health Equity Cook County. It's beyond disappointing that we are here again demanding that the system meet its mission. During these challenging times, one of the nation's largest public health systems, we should be a leader in the area instead of a system that is barely visible. There are no posted signs in multiple languages declaring the system's commitment to care for all regardless of immigration status. Policies and procedures of the system have not been clarified or even identified, and staff training in these rapidly changing times is the same training given in 2017. This training generated, just for information, complaints to the 2017 and 2018 board. It is critical to remember that while Latinos may form the largest immigrant community, the people under attack represent the world, those of Europe, of Muslim faith, and immigrants from Africa, Asia, and the Caribbean are also enrich Cook County. In 2018, a coalition of groups came together throughout the county and graded the health system's response to the attacks on those we serve. In 2018, the grade was a D-. Today, we can only say that the grade looks close to an F. Demands of the community and the current grade. Our first demand was place abundant and clear signage in multiple languages, assuring a welcoming institution. Our second demand, staff training and resources addressing the needs of marginalized patients and their families. 3, establish a referral system for legal services, know your rights, information, and other resources needed by immigrant and other marginalized communities. 4, clarify, revise, strengthen policies and procedures that focus on protecting immigrant and marginalized patients. Identify and monitor indicators and neighborhood stress in immigrant and marginalized communities. Currently, we have Cranes with a lead article that 26th Street is empty. It shouldn't be Cranes that's giving out that information. It should be our health system.
Pardon me, you have
Design and
I'm sorry.
implement.
Excuse me, Ms. Avila, you have 1 minute remaining.
Okay, design and implement best practices for clinical and public health providers to deliver appropriate care. We again demand the system establish a task force that will move forward with what is really just providing quality care. Thank you.
Thank you. The next speaker is Dr. Linda Ray Murray.
morning. I
Morning.
come before you today on behalf of the Health and Medicine Policy Research Group. 8 years ago, we came before your predecessors to discuss the deficiencies in the reaction of county health to the challenges of then new President Trump. I have attached that previous testimony. If I thought history repeated itself, I could just simply say ditto. What we face today is far more dangerous than Trump's attack on our communities of 8 years ago. Already, ICE SUVs are cruising our city, creating fear. Trump's decision to rescind protected areas policy creates an even greater danger to the communities we serve. As a past president of the American Public Health Association, I've spent hours in national and regional meetings strategizing on how to protect the health of the public from his efforts to turn back history. Immigration is just one of many fronts where Trump is instituting policies that threaten the health of us all. These changes in ICE policies and procedures endanger all of us by undermining trust in health facilities and creating panic that force people to postpone or avoid necessary care. In 2017, the recommendations presented to this board were drafted by a coalition of Cook County, the 7th Cook County District Health Task Force, UIC School of Public Health, and Health and Medicine. The second Trump administration is threatening the fundamental rights of all who give aid and comfort to those they deem undesirable. In addition to our 2017 demands, it is critical that all county staff receive mandatory training on updated policies and procedures. Our staff, the unions that represent them, must understand their rights and be prepared to fulfill their obligations as healthcare workers to our patients and the communities we serve. It is critical that all staff be reminded of their rights under the 4th and 5th Amendments of the Constitution. Clear signage designating private areas of Cook County health facilities where ICE should not be permitted without a valid judicial warrant should it be immediately posted. This board should order an evaluation of all data collection practices in our system to guarantee that immigration status is not collected and so cannot be misused by immigration authorities. The internal system of county health should contain links to immigration response networks of our area, including state, county, and city resources. This is necessary so that staff can provide basic health for our patients. A monitoring system should be set up to document all interactions with immigration, and regular reports should be made to this board.
Pardon me, Dr. Murray, would you have 1 minute remaining?
Thank you. In 2017, the Board of Directors agreed with the spirit and intent of our recommendations. Members of that 2017 board urged rational action. However, the senior leadership failed to implement an acceptable plan. You are a new board with a different CEO. The quality of care that Cook County Health offers the people of the county rests with you. It is a responsibility you cannot delegate. We urge you, the board, to set clear expectations and hold Dr. Makaitis, our CEO, accountable. Thank you.
Thank you.
The next speaker is Alejandra Ibanez. Oh, I'm sorry.
Excuse me, I'd like to acknowledge Commissioner Lowry's present.
Thank you, Chairman. I would like to be added to the roll, please.
Will do. Thank you.
Thank you.
Please.
Thank you. Good morning.
Good morning. Good morning.
My name is Alejandra Ibanez, and I'm the Executive Director of Illinois Unidos, a statewide coalition made up of over 100 health providers, Latinx health providers, policymakers, and public health allies. We're dedicated to achieving healthcare equity for Latinx and immigrant communities. I am here today to sound the alarm about the devastating impact of recent federal healthcare policy reversals on our most vulnerable populations, and to call on you, our Cook County leadership, to stand with us in protecting access to health care for all. Illinois Unidos was born out of the necessity of the COVID-19 pandemic, when Illinois' 2.3 million Latinx residents faced disproportionate impact and the highest mortality rates at the beginning of the pandemic. These were our essential workers, individuals laboring in factories, warehouses, and other dangerous environments, who kept our economies, local and national, moving forward, often at great personal cost. Today, many of these same workers, if they survived, are living with the highest rates of long COVID, a chronic condition affecting between 17 and 20 million adults in the U.S. and nearly 6 million children in the U.S. Our work at Illinois Unidos evolves. Most recently, we were able to hire bilingual, bicultural health navigators through a state grant to help DACA recipients, these are deferred action on childhood arrivals, and deferred action on labor enforcement workers, have access into the ACA marketplace. Yet today we are facing even greater challenges. Recent federal executive orders, as you've heard, threaten not only immigrant communities, our LGBTQ and trans families, but also all Americans who rely on healthcare systems like Medicare, Medicaid, and the ACA marketplace, and your own institutions. These reversals eliminate initiatives to lower prescription drug costs, weaken Medicaid pilot projects, and dismantle progress in expanding access to care. This is not just about policy, but about lives. I know critically and personally how important your work is. My own mother, while uninsured, relied on Cook County's healthcare system to fight her second battle with cancer.
Pardon me, I'm sorry, you have 1 minute left?
Thank you. You serve 500,000 patients annually. Your dedication is a lifeline for families like mine, and I am truly grateful. But now more than ever, we need you to do more. We need you to be champions for immigrants, champions for LGBTQ, and all American families. I ask you to follow 7 steps to protect communities you serve. Develop a strong written policy to safeguard your immigrant workforce and patients from unjust ICE enforcement. Designate personnel to review and handle ICE warrants and subpoenas. Train all staff and volunteers on how to appropriately respond to ICE requests. Understand the distinctions between public and private areas, particularly given the rescission of protected areas under the latest executive order. Document all interactions with immigration enforcement. Collaborate with this robust immigrant response network, many of whom are here this morning. And lastly, expand telehealth services to better reach vulnerable populations. Thank you for your time, your leadership, and your commitment to caring for our families. Together, we can assure that healthcare remains a right, not a privilege, for everyone in Cook County.
Thank you.
And the final speaker is Wesley Eplin.
Good morning.
Good morning.
My name is Wesley Eplin. I'm the Policy Director at Health and Medicine Policy Research Group, which focuses on social justice and health equity in Illinois. Most of us want nothing more than to show care and support for our loved ones. Unfortunately and unjustly, the current federal administration, led by Donald Trump and his MAGA movement, is scapegoating people who have courageously come to the U.S. seeking a better life. Several individuals and organizations, including Health and Medicine, gave similar testimony to this issue eight years ago. Here we are again. President Trump and his staff are directing violent immigration and customs enforcement raids on people, sowing fear and division. This reality threatens the mission of Cook County Health, both because people are fearful to leave their homes, even to seek health care, and because there is some risk that ICE will not leave sensitive locations like health facilities alone. While we are glad that Cook County Health is focused on training staff to support immigrant rights, as we shared this week in a meeting with Dr. Makaitis and other CCH staff, we have concerns about the training and associated policies and protocols. To be fair, there have been some improvements to the slides based at least in part on our feedback, and we're glad for that. Still, the training should be made to be mandatory and should be more fully reviewed with external partners to ensure the training and associated policies fully protect patients and your workers. Our main recommendation is to establish a committee to improve your efforts to support patients facing these increased threats. The committee should address the following: internal policies and procedures, staff training, making legal referrals, improved signage, monitoring community stress, and following best practices related to care, support, and bedside manner. Cook County Health should work with external immigrant rights legal groups as members of this committee. We also recommend having Cook County Commissioner Alma Anaya, who has proactively provided her perspective to Cook County Health about these issues, as the leader of this committee. Both Trump and Tom Homan, the director of ICE, have said that Chicago is a focus of raids on immigrant communities. The actions and threats of the Trump administration are designed to divide and intimidate people. They meant what they said, raids have begun. We don't know where the raids will happen next. Part of your job is to do everything in your power as board members and CCH administration to ensure that Cook County Health hospitals and clinics are welcoming and affirming spaces that are safe as possible for all patients who come through your doors. Thank you.
Thank you.
That concludes the testimony.
Thank you very much. Thanks to each of you who came today and shared your input and guidance. We appreciate it, and we appreciate your advocacy and your care. And Dr. Makaitis, during his CEO testimony, if you'd like to remain, we'll address, along with our council, the work that we're already doing and our staff, and appreciate it. So thank you. Next, before we move on, I'd like to entertain a motion to allow Director Lowry to remotely participate in this meeting as a voting member. So moved.
Second.
Thank you. The motion has been made and seconded. Is there any discussion on the motion? All in favor? Aye. All opposed? Thank you. The ayes have it. The motion carries. The committee chair, the minutes of the December 20th board meeting are being presented for your approval. Are there any corrections or revision needed to be made to these minutes? December 20th, they're in your packet. All right. Thank you. Hearing none, I'd like to entertain a motion to approve item 4A, the board meeting minutes of December 20th, 2024.
Second.
Thank you. The motion has been made and seconded. Is there any discussion on the motion? All in favor? Aye.
Aye.
All opposed? Thank you. The ayes have it. The motion carries. Next, Director Robinson will review the Human Resources Committee special meeting minutes. Director Robinson.
Thank you, Chair. The Human Resources Committee held a special meeting on Thursday, January 9th at 11:30 a.m. The next regular meeting of the Human Resources Committee will be held on Friday, February 7th at 11:30 a.m. The action items: the committee considered one collective bargaining agreement, which included an economic package between the Cook County and SEIU Local 73 representing optometrists. The CBA was fully reviewed by the committee in a closed meeting and was recommended for approval by the committee. It will not be re-reviewed today, but if any directors have questions, we'll hold off on approving the minutes until the questions are addressed in closed session later this morning. Otherwise, if there are no questions, the minutes are being presented for consideration at this time. Are there any questions that need to be addressed in closed session?
Sounds like there are none. You were complete in your last session. Thank you. I'd like to entertain a motion to approve item 4B, the minutes of the special meeting of the Human Resources Committee of January 9th, 2025, containing the following action item. Approval of one, the collective bargaining agreement, including an economic package, wage increases in healthcare between the County of Cook and the Services Employees International Union, SEIU, that's commonly known, Local 73, CTW/CLS, representing optometrists.
Second.
Thank you. The motion has been made and seconded. Is there any discussion on the motion? Hearing none, all in favor? Aye.
Aye.
Thank you. All opposed? The ayes have it. The motion carries. Thank you, Director Robinson. Next, Director Bott will review the Quality and Patient Safety Committee meeting minutes. Director Bott.
Thank you, Mr. Chair. The Quality and Patient Safety Committee met on Friday, January 17th at 9 a.m. The committee approved the following action items, which are included in the minutes. Approved one, Stroger Hospital Department Chair reappointment. Approved Stroger and Provident Hospital medical staff appointments, reappointments, and changes. The committee received the following reports, which are included in the minutes: Operational Excellence Dashboard, Goals and Tactics, Provident Hospital Site Review, Stroger Hospital Site Review, ACHN Site Review, and a Regulatory and Accreditation Update. The next meeting of the committee is Friday, February 21st at 9 a.m. There are no other questions on the minutes. They're being presented for the board's consideration at this time.
Thank you. Do we have any questions? Thank you. I'd like to entertain a motion to approve item 4C, the minutes of the meeting of the Quality and Patient Safety Committee of January 17th, 2024, containing the following action items: approval of the Stroger Department Chair reappointment, and approval of the proposed Stroger Hospital in Providence Hospital medical staff appointments, reappointments, and changes.
Second.
Thank you. The motion has been made and seconded. Is there any discussion on the motion? Hearing none. All in favor? Aye.
Aye.
All opposed? Thank you. Thank you. The ayes have it. The motion carries. Next, Director Ryder will review the Finance Committee meeting minutes.
Thank you, Mr. Chair. The Finance Committee met on Friday, January 17th at 10:30 a.m. The next meeting of the committee will be held on Friday, February 7th at 10 a.m. The committee considered the following action items, which are included in the minutes. We conditionally approved 19 contracts and procurement items. Number 1, 2, 12, and 18 are pending review by contract compliance. On the screen, you'll see the contractual requests from the Finance Committee meeting whose fiscal impacts are greater than $1 million, which are highlighted for your information. We received and filed grant award related items. The committee received the following reports, which are also included in the minutes. The fiscal year 2024 Q4 report of contracts executed under the authority of the CEO, which are contracts under $150,000. Report of the November year-end preliminary financials. The monthly report on our agency usage reduction plan. Our follow-up from one of our follow-ups from the meeting is regarding revenue cycle. A number of questions were raised regarding efforts and methods for financial eligibility assistance for uninsured self-pay patients. Additional data was requested regarding the subject to see if there are any opportunities to further reduce the number of self-pay patients who do not qualify for assistance or choose to not go through the eligibility assistance process. And I do want to, as part of that follow-up, to get the data, but also to indicate that I think we've made a lot of progress in this area over the course of the last, for me at least, the last 8 years. Another follow-up was regarding the agency reduction report. Is to have a more comprehensive, comprehensive report will be provided that includes nursing physicians and those related to the Hectone transition. If it's possible to have it ready in time, it will be presented at the February 7th meeting. Otherwise, it will be presented in March. And to make sure that we clarify that, the report that we were receiving on a monthly basis was originally designed to report on the agency reduction as it impacted areas that were not related to our doctors, Hectone, and nurses, but now it's been requested that we include all of that. And we've received reports, just for the record, on specifically on nursing in the past. So this is not a case of first impression. We've had received reports on it, but it will now be part of the monthly report. If there are no other questions, the minutes are being presented for the board's approval at this time.
Thank you, Dr. Ryder.
Director.
Director Ryder, not a doctor.
I do have a Juris Doctorate.
There you go.
Some could argue.
JD doctor.
Some could argue.
JD Ryder. Do we have any questions, directors? Thank you. I'd like to entertain a motion to approve item 4D, the January 17th, 2024 Finance Committee meeting minutes, which contain the following action items: conditional approval of the contracts and procurement items, pending review by contract compliance, and review and filing of the grant award related items. Do I have a motion?
So moved.
Thank you. The motion has been made and seconded. Is there any discussion? None? All in favor? Aye.
Aye.
All opposed? The ayes have it. The motion carries.
Mr. Chairman, I would
Yes.
like to note on the agenda, we will be receiving another report from on our finances that are occurring prior to our committee meeting next week because of board timing. I just don't want to make sure that give some context because we have to report it. We have to report it earlier next month because of when the county board's happening.
Thank you, we're working on that. Appreciate it. We do not, and to your point, we do not have any contracts being presented directly to the board for consideration, so we can move to the next item. And I will defer my time to the CEO later, so we have more time. The next item on the report is a report from the Chief Executive Officer, Dr. Eric McIdris.
Thank you, Chair Taylor.
Thank
Good morning again, directors. We have three items to present to you today. The first is an update from Jeff on the current state of the work around immigration. The second is ARPA update, and the third will be the first kind of big step in strategic planning. As everyone's aware, we are spending 25, getting ready to launch our 26, 7, and 8 strategic plan. So this is kind of that first step. We're going to take a wide view of kind of the current state of things we're considering, very kind of informational, just to kind of get the juices flowing around the strategic planning process. Okay.
Again, directors, just the key word that he said, so we all remember, is informational update on our preparation for the strategic plan. This is not the strategic plan. All right, thank you very much. Jeff.
Thank you. Good morning. Just wanted to give you an update on the activities that have taken place to prepare ourselves, our employees, and our patients for what we anticipate may be increased activity by immigration and customs enforcement. You know, we proudly, I'm sorry?
There are no questions, Jeff.
Okay. You know, at Cook County Health, we proudly care for all residents, regardless of their immigration status. We have prepared a training that we provide to all of our personnel. I have provided that training this week to all law enforcement personnel and security personnel. Provided that training to our leadership forum, which is several hundred managers and leaders across the organization, and to over 450 people who work in our ACHN centers. I am currently working with both medical leadership and nursing leadership to schedule trainings, which will take place on all different shifts and for everybody across the organization. We are very well aware of the fact that ICE has lifted its restriction, its longstanding policy that they would not provide enforcement activities at certain protected spaces, which include healthcare sites and hospitals. And our training explains to our personnel exactly what to do should an ICE officer appear at one of our facilities. We treat ICE officers the same way we treat any other law enforcement personnel. The guidelines we put in place, the training that we do, is fully compliant with both protecting our patients' HIPAA rights and making sure that we do comply with any judicially issued warrant that we are required to do by law. And that is the only way that we would cooperate with ICE, is if they show up with a judicially issued warrant. Our training makes certain that we do not require frontline personnel to decide whether something needs to be complied with. A law enforcement officer and a lawyer for CCH will be the people making the decision on whether or not a document is one that we have to comply with. And without that judicially issued warrant, we would not let ICE officers into our facilities. I heard earlier there was some reference to the fact that some public spaces exist within our buildings and others are private spaces. I want to reassure the board that we do have an advice letter from the state's attorney's office that says every single one of our ACHN clinics, the entire building, is considered a private space, not a public space. And so that's where we are right now. The training will continue. Anytime anybody wants one, I'm more than willing to give it. And we are trying to make certain that we reach everyone within the organization. We did provide this same training 8 years ago. I personally visited every single site at which CCH sees patients and provided a training for all personnel at that time. The training is being done pursuant to a policy we have on when law enforcement officers can access our premises. That policy is consistent with the policies at other hospitals and health institutions around the county.
Jeff, thank you. Fast move, Director. Any questions, directors? Director Ryder.
Yeah, Jeff. So Jeff, the question's been raised is whether the training is mandatory. What you've said is that you, are putting everybody into the training. So do people can people object to the training, or is it a directive to attend the training? And you would
So
agree with-
I'm working with both nursing and physician leadership right now to make sure that we reach everybody. I've never heard of anybody opting out of this training, but we're still working out the mechanisms by which we'll track attendance at the training sessions. The training sessions I've given so far, just so you know, our employees have been extremely engaged. They ask a lot of good questions, and they have a lot of good ideas on ways that they can proactively assist our patients.
So we are expecting everybody to take the training. The tracking piece, I think, is where Jeff is, be a little bit, we're working through whether this is like an LMS training, which I think was less engaging than kind of having the discussion directly with someone and having a Q&A at the end.
Okay.
So we're kind of working the logistics of that, but the expectation is everybody's doing this.
What about the signage? And this is probably more for you, but informed by Jeff. What about the signage on welcoming environment, things like that?
Yeah, so we've had kind of the all are welcome. We're punching that up again. That's going to be rolled out again. We've also got the Know Your Rights handouts that will be posted and also handed out in patient encounters.
Okay. And are we working with any community organizations or referral services that, resources beyond just the Know Your Rights, which is here's where you can go, and making sure that it's available. One thing, my immigration work is reflexively people, the average person's like, oh, it's got to be in English and Spanish. It's like, well, yeah, it's got to be in English, Spanish, Polish, Mandarin. It's got to be in a lot of different languages.
We have 5 languages now, including Ukrainian, which has now become our 5th most common language within our patient populations. Oh boy. I think you hit the high ones: Mandarin, English, Spanish, Ukrainian, and probably Polish is 5. Yeah. So,
Okay.
Yes, we are going to have a more formalized recurring meeting that's happening with a lot of our community partners, including some labor leaders. That's going to be set up every other week to check in, kind of a listening session, get feedback, and figure out, where there may be additional opportunities to engage.
Okay. I'm doing a lot of work around citizenship and Know Your Rights right now as well with some of our partners. So I'm happy to offer any guidance on people that would be good folks to work with. I also sit on the board of the Illinois Coalition of Immigrant and Refugee Rights, which is a it's the CFL for the immigrant community, where a lot of immigrant, migrant, refugee oriented groups could are associated with them as an umbrella organization.
Okay.
Thank you. Any other questions? I'm sure we have a few questions or comments. Let's go to the Director Robinson and then Director Green.
Question for Jeff, and I'm not sure if this has been thought of, but is the parking lot considered to be public or private?
Yeah, parking lot spaces are considered public.
Next question would be, are there any other routes that individuals could access medical care without necessarily having to go through that particular space?
So, we have entrances all over, the hospital, not just through the parking lot. But once you're outside our doors, there's very little we can do to control access. We also, within our hospitals, we have other areas that are considered public: the front lobby, the cafeteria, et cetera, the gift shop. There's very little that can be done to control access to those spaces also. It's only the patient care areas in the hospital that are considered private, and the entirety of our ACHN clinic buildings are considered private.
So telehealth access, Director Robinson.
Telehealth access.
Yeah. Now, the third question comes, thanks.
Director Green.
Thank you. I was going to say that I love that we recently started talking about expanding virtual care options. Of course, there's some of us that love the good old physical exam in person, but having the flexibility of virtual care, so thank you all for that. For my clarity, is the training mandatory? I didn't hear a yes or no. And it could be me. Is it mandatory?
Yes.
Yes, thank you. And then, the last one, with respect to private spaces, thank you for bringing that up. Is there a way to designate private spaces for staff and community at large so they know what's a private space and what's a public space? And is there opportunity for signage regarding that, and also signage online regarding the fact that people have access to virtual care? So communications regarding what is a private space, what is a public space, so people know without asking, and then, expanding the, knowledge that people have the virtual care, option.
Yeah, I think, so we can certainly talk with Alex, Normington about how we continue pushing the telehealth options. It's very out there on social media, it's on our website, so, but I think to your point, right, kind of reinvigorating that, yeah, it's a great suggestion. Public-private, we'd have to talk about kind of how we would do that, but I think it's a good suggestion, right? Our plan really is that certainly anybody in a public space who would be outward, even in the cafeteria, for example, our food service team, that they would be trained in this to understand if they see activity, they're calling hospital police to, get them engaged. But we'll take that back in terms of kind of how we can signal it's public or private. Now, ACHN, we have gotten that opinion solidified, and we're drawing that line at the door that the waiting room is not considered public. So,
Thank you.
I think the thing that's gonna cause the most anxiety here is that we don't know how they're gonna do this, and, they launched this yesterday by going into a seafood, wholesaler, and they ended up detaining a Navy veteran, and they took in 3 people, and I think that's sort of like a, feeling themselves out, getting their feet wet, and, based on the way that these policies have been rolled out, they're being done as a way to, they look more political than they look policy, right? So that means that the next shot will be, as it were, or move would probably be to go to a high-profile target that, they get to that high-profile target, conduct a raid, and they'll probably never go to that target ever again, right? So it's like, you can think, for high-profile targets, like, they're never going to come here and do it because it wouldn't be sustainable. They may do it once, right? They may do it once just to make a point. We're sort of, we're on the top 5 list, if not the top 3 list of places they find sexy to do this.
Directors, I'd like to recognize, I'll come back to you, Director Kev. I'd like to recognize, Director Lowry, Commissioner Lowry, who has his hand up.
Thank you, Chairman, and thank you, Jeff, for the overview. I would ask that we give a synopsis of this initiative in our CCH report, which is then forwarded to the Board of Commissioners. We're out front on this, and we don't need a resolution to be filed to have us address this. So again, I just want to be purposeful and make sure that we provide the information that we're able to provide to my colleagues on the board with each reporting session every month. Thank you.
Well, the benefits of having a commissioner as our vice chair of our board. Thank you, Commissioner. Appreciate it. We'll come to recognize. I go to Director Kim, just to be clear, then Harrington, then Terrell.
Just a quick question about the content of training. One of the testimonies mentioned that training wasn't adequate or got an F or something. So I'm just wondering if the new training this time around is different from 2017, and whether people actually get input from community partners to improve training content.
So
Do you want to-
yeah, I can
Yeah.
address that. And I'll take your last point first. As Dr. Makaitis indicated earlier, we're going to be setting up a recurring meeting every 2 weeks where we will include external partners to get their insight and input. And we are always looking ways to improve our training if we can find them. And there have been some tweaks in the deck that we use to present the training based on that input. The law has not changed since 8 years ago, and so the underlying policy and overall, content of the training has not changed significantly. But we have made a number of small changes to reflect input we've received.
Well, at the core of it is really just encouraging and emboldening our frontline staff not to feel like they're on an island, that they have support, that they have, take these steps, very concrete, call these numbers, get hospital police, get legal risk on the phone, right? They're not out there by themselves having to make these decisions, right? They're supported and they have help. So that's the expectation, is they follow that. So that's really kind of the core of the training, especially for the frontline staff.
Yeah, and look, we're not expecting everybody to be lawyers and experts and in everything, right? That's the idea of having the experts, to have the staff and get our staff on staff and get our staff up to speed as much as we can and support them, right? So that's part of it. Director Harrington.
Okay, real quick, the frontline staff, do they have a standard operating procedure? So their particular disposition doesn't come into play?
Yes, they are given a list of the people who have to be contacted and the phone numbers, and they're told to contact the following people in this exact order. And those are the people that will then advise them on what their next step needs to be.
Thank you. Director Harrington.
Yeah, two things, and I want to pick up on a term that Director Ryder used. My anxiety level went up as soon as I knew that Trump was going to be president again, and it hasn't gone down since then. So I remain anxious about what he may do during this current term. And I heard this morning they're trying to, someone in Congress is suggesting that that they extend the term for president to 3 terms. So we'll see what happens with that. But I think, and I also want to point out that I have every confidence that we will do everything we can to prevent some of these things from happening. And we're prepared to do what we can. But ultimately, we have to do what we can when something happens. And what I've learned from past experience, no matter how much you train, no matter how much you're ready for something to happen, it's nothing like being in a real life situation where things are happening and you're adjusting moment to moment. So our ability to pivot and make good decisions moving forward is the most important thing moving forward, because things are going to happen that we're not prepared for. And when those things happen, we have to be able to pivot. So I commend Jeff and Director Makaitis for what they've done. But we'll probably be doing this for the long term, because things will change, and at some point, something's going to happen. And that will be our lesson, to learn from that and not have the same mistake occur again. The other thing I want to pick up on this whole issue of virtual care, and every patient encounter is an opportunity to remind them that they can have their visit virtually. So it's not just what we put out there, it's how we communicate with patients in real time. So every time a patient comes in, you can remind them that they have the option for virtual care, and they may take it up. But you may also want to ask if they have the ability, because the other side of that coin is to have the ability to do that, and many of our patients may not have the ability.
But just to add to that, since I do have some expertise in that particular area, there are ways to reduce the inability of the person lacking the capability of having internet access.
I know that.
There's
I mean,
things that
I'm
can
just
be done.
saying, if they ask, they'll know.
Right, we'll provide them.
So Director Harrington, if I could, so to your first point, I completely agree. We've actually activated our incident command. So we're meeting daily to discuss these things right now, right? So that there's that feedback loop where we're able to have our kind of more satellite leaders, right, come in on the call. Is there any activity? Also, it's a means of us disseminating, here's how we tweak things, here's updates, here's what we're doing. And then as been mentioned a couple of times, we have every other week, we're scheduling now kind of the external discussions. On the off weeks, we're having internal work groups to kind of continue, looking at how we adjust and adapt. I do appreciate that suggestion around providing kind of just that primer of, here's the virtual capabilities. That's something I'll take that to Alex, and we can talk about because we're already doing kind of the Know Your Rights poem cards. We're rolling that out now, as a resource in the clinic, so we maybe couple the two things together. So, thank you.
Director Sorrell.
Thank you, Director, and thank you for what you've done so far. Jeff, Dr. Makaitis on this. I have seen on social media the Know Your Rights information. I wonder also what types of messaging we can include in social media, even maybe so if someone calls in so that they can hear as part of the waiting messaging, hey, we are doing X, A, B, C, and D to help to assure you, because sadly, as Director Harrington said, there is a lot of anxiety there. When I'd also asked in November about any types of stress supports. I know Dr. Nutter, I'd included you in that discussion too, what we can do in the community, even potentially to provide types of mobile or virtual outreach to be able to help in coping skills, activities. I know we already provide a lot of behavioral health messaging, but certainly we had discussed even after the election how to be able to start that. So certainly that's going to be very impactful in trying to help allay those concerns. Additionally, from what Dr. Harrington had stated, have we had a drill so that we have an active practice to be able to then evaluate what potential issues may have occurred, and then to potentially make sure that we're up to snuff, as you said, when something may actually happen?
Yeah. So thank you for that. And yes, I'll discuss with Dr. Nutter about, kind of the behavioral health support around anxiety and all of that. But we actually discussed yesterday in our debrief about what's testing the system as we roll out the trainings, right? How do we just kind of pop in random clinics and just say, okay, hey, I'm an ICE agent. What do you do, right? And just make sure that the frontline staff is, they're not, they have the resource in front of them. They know the phone tree. They know what to do. So yeah, testing the system, absolutely. Yeah, we haven't started, but yes, it was. Yeah.
And also as a reminder, I know we had discussed in December, I think it was November, about some of the pharmacies closing. Going to pharmacies has also become a concern because much of that is also public space. As part of the telehealth information that we disseminate, please make sure that we also include what types of mail-in or mail-order pharmacies for receipts of medication, because we may be able to provide the visit, but if someone is anxious about actually going to get the medication, then that's also going to be a barrier. So make sure that there are ways that we can do direct mailing and other types of communication to make sure that patients have less public footprints should they need them.
Thank you. Good insight.
Just put a pin in it too, sir. I'm sorry. Go ahead.
We'll make a comment because I need to now with someone else. Go on, please.
That's why the mandatory attendance is required, because everything is very fluid.
Right.
And if people don't attend,
Then they don't get the training.
mistakes are made.
Correct.
I think even to Director Harrington's point, right, even with the knowledge, right, when someone's in front of you with, a firearm and a badge, right, people can lose their nerve, and right, there can be kind of that, so
Very much so.
it's really ingraining that process and ensuring that people feel supported. So.
I'd like to acknowledge you. Thank you. Director Bott, who's remote.
Thank you, Mr. Chair. I just picking up on Director Sorrell's comments and agree with the thread of conversation. Appreciate all the work on this and thinking. We could also, I think, look to emergency preparedness tools and training. We have those as it relates to the scenario planning and the drills. And then I'm eager to hear about how we're thinking about behavioral health strategies, which Dr. Makaitis, I think you alluded to following up on. But I think that there's going to be increased need there. And then again, how we leverage digital and virtual effectively in this environment. So thank you.
Thank you. Good input. I'll say, I think one of the directors said it earlier, right? We're in volatile, uncertain, and changing times, right? Which require all of us, staff, team, et cetera, to act with agility, to learn, to adapt as we get this. And I appreciate, look, nobody knows exactly what's happening, all the work that everyone's doing. So I know oftentimes we come in here, we're like, you need to do more, you need to do more, you need to do more. Staff, thank you for what you're doing. Thank you for all the work you're doing. Thank you for your dedication. We appreciate it. Thank you, team, for what you're doing, board directors and all. We really appreciate it. Thank you. Any further questions, directors?
The last quick one, and obviously this is already in place, the emergency mass texting or mass messaging. Is there going to be a test of that, or the opportunity, not a test where you would say something was going on, but just to send out? So obviously that's probably already in place, but just to name that in this group of things.
So Director Green, are you, in terms of alerting staff that there's activity, or patients, which?
No, I mean, the staff, it's, and not saying that we would alert them in every situation, but making sure the foundations of it are in place, that it's on and that people are reachable. We saw this during COVID. I was a part of the city of Chicago, but also, the entity I was at, just a litmus test, just to make sure it's working, there are no glitches, everybody's emergency number is updated. Something we can do that's proactive right now that may, in the event that we needed help in the future. I know you already got that, I just want to put that there.
No, thank you. I see Angela Bannon over here. She's our Chief Technology Officer, shaking her head. Yes. Okay, thank you. All right. Andrea, can you come up? Thank you. Thank you both for the update.
Good morning.
Good morning, Andrea.
I'm Andrea Gibson. I'm the Chief Strategy Officer. The first item that we're going to go through is the requested update on ARPA. We've been, there's been a variety of milestones in the ARPA progress. First was in September, when we had to complete our hiring for the positions. And the second was supposed to be at the end of this past year to obligate the funds through contracts, subrecipient agreements, et cetera. So that was the original obligation deadline in August. Just so you have a frame of reference, we had obligated $97 million, and by the end of the year, that increased to $148 million. So the non-obligated, non-personnel amount was $4.3 million as of January 8th. But we, in December, worked with the county to leave the program budgets the same. So there will be no cuts to these programs, just the funding source. They put some of the ARPA funding towards revenue loss rather than these programs, and are swapping it out with corporate funded dollars through the county. So this means there's no lost money or need to repurpose any of the funds. Also, we have spent close to $55 million of the $174 million for ARPA. So the next deadline, and we can go to the next slide, Deb. So we've got a few straggler contracts and agreements to finalize. We'll be managing the budget rollover process. To adjust any unspent dollars from 2024 to fold them into the 25 budget. The next frontier for ARPA is spending the dollars. We have the people in place, we have contracts in place, and now we need kind of a drumbeat of spending against the goal. So the deadline is the end of 2026, and so we have some, a per month goal of about $5 million each month this year to get us in good position for that deadline. Any questions about this?
Thank you.
How often will we get updates, so we know where we are?
You tell me. How often would you like updates?
I think the regular board meetings are good.
Just every month? Okay.
Thank you.
All right. So the next presentation has to do with the strategic planning process. So last month, we came before you and gave you an update on where we are on the current strategic plan and where what goals we set for this coming year. Now, with this presentation and the other presenters that will be joining me over the next hour, it will lay... Hour? Pardon me? I believe the schedule said I had until 11:05.
I'm just curious. This is 2019. Exactly.
So we can beat that target. Our goal these next minutes, whatever, will
For the time allowed.
will be to provide some context about the context that we're working in to develop the strategic plan. We are going to be presenting you with a lot of information over the next 6 months relative to the strategic plan, and this is to kind of set the stage. And we're also planning smaller group meetings with directors to get feedback, and so we'd really like to present all of this information today and then maybe have more detailed discussions in those meetings. What we have planned is to just level set with some basic information about the demographics, who we serve, what our service summary is, looking around the Cook County market, what is the market scan in healthcare, also looking at the federal and state landscape, and public health is going to provide us with an environmental scan of the biggest public health issues that we should be thinking about. So we can go to the next slide. So I wanted to first go back to the authorizing ordinance and just share what the requirements are for the strategic planning process. It does require a strategic plan every 3 years. It requires that the system board recommends and submits a strategic plan to the president and the county board for approval, and it requires the system board to regularly re-examine progress against the strategic plan. So I think we're in pretty good shape on all those fronts. Next slide. So this shows the timeline for the strategic planning process. So we start on the left where we are today, and we will have, at each board meeting, we will present some additional information. We will be getting feedback from employees, from community members on what our strengths, weaknesses, opportunities, and threats are, what we should consider for the strategic plan. We'll be coming back to you with the long-term facility planning process that's underway. And then we'll have a draft strategic plan for your review and vote. And if it is approved, it would move to the county board, and then to prepare us for implementation in December. So turning first, next slide, to the demographics and service summary. You can look here, you know, I like to think of our health system as built with 3 major components. We are a provider of care, we are an insurance plan, and we are a public health system. And you can see some of the key facts, key numbers that tie to those services here. Next slide. On our patient demographics, none of this will surprise you. We serve a majority non-white population, and we serve over 40% of a population that identifies as Hispanic. Next slide. Looking at these 2 maps, on the left is a heat map of where our patients come from, and on the right is our county care members. You see a lot of overlap between the distribution of the patients and the members, and an ongoing strategic opportunity to attract more members into our system as a provider. Next slide. Looking at some of the trends that we've seen over the past 2 years, we see total discharges, average daily census, kind of getting close, increasing year over year for sure, and increasing as we get further away from the beginning of the pandemic. Both at Stroger and Provident, we've seen big decreases in the left without being seen percentage. And then in recent years, increases on deliveries a lot of that driven by the new arrival population. Shifting to the next slide for Provident, we see some similar trends, maybe more dramatic increases because of the reinstitution of ambulance runs. So you see a big uptick in discharges, average daily census, some increases in surgical cases, a little bit of a drop this past year. And left without being seen overall for the year was at 4.2% last year, but we ended the year below 2%. So lots of really good work there. Next up at ACHN, next slide, please. We see that we're holding steady in primary care and specialty care year over year. We are improving our collections on primary care, which is a testament to both the work in the clinics and registration improving, as well as our revenue cycle team. On the upper right-hand side, I did want to point out a trend with county care utilization. The impaneled members to Cook County Health as a provider are coming into care more. We're providing more care to those individuals, and that's been a concerted effort to make sure we're following up with that population to come in for routine care. Next slide. We talked a little bit about us as a provider. This is a very familiar slide to you. This is our Medicaid managed care plan, County Care, and the largest Medicaid plan in the county. Next slide. And last but not least, our public health department, does a lot of work in health protection, in epidemiology, and generally promoting better health, conducting screenings, providing support through nursing services. So now we're going to shift with the next slide to a market scan that looks at the Chicagoland, the county market, and a lot of the themes that we're going to see are national themes. There's a few things that are a little bit different in Cook County, but in summary, we're seeing our population aging. We're seeing the underserved population growing. We're seeing a very complicated, competitive market. A lot of health systems are targeting more insured patients and specialty care. There are a lot of access challenges throughout Cook County. There are a lot of pressures on safety net systems, financially and otherwise, to continue to provide care and exist. Quality is a differentiator in the market, and is the North Star of to stay focused on quality as a way to access or a way to attract patients. And finally, everyone's facing workforce shortages, and it's pushing all of us in the healthcare industry to think a little bit differently about workforce. So next slide. So the first thing I wanted to point out here is that overall, the county is projecting a population decline over the next few years, but the growing area of the population is over 65. So health systems will need to respond with providing more services targeted at that population. Next slide. We provide, and this is no surprise to anyone in this room, a disproportionate amount of care to vulnerable populations. If you see on the graph, the first three components of the graph are overall inpatient discharges by payer. And in that little red outline is the kind of what we're calling vulnerable populations. So that's Medicaid plus uninsured. And you can see that Stroger and Provident is a significantly higher percentage of treating that vulnerable population. In that particular, the vulnerable population, there's a lot of complexities in providing that care that include a lower life expectancy, higher rates of infant mortality, harder access for behavioral health, food access, housing access, and concerns about community safety and violence. Next slide. So in the market, we are seeing, there are a lot of hospitals, a lot of health systems in Cook County. And, looking on the circle to the right, we are only 2% of the market. And it's a tough market to distinguish ourselves in terms of attracting patients, and a lot of the other health systems are making changes to realign what services they're providing. Next slide. So, and this piggybacks on the last slide. Like, we are seeing more of health systems expanding their suburban facilities, targeting insured patients and specialty care. We are seeing additional pressure being put on safety nets to fill gaps that are created by that process. We are seeing a significant shift in value-based care, or to value-based care, throughout the nation. So that's an important thing for us to continue on. A lot of investing in innovation is important at this point, again, as a market distinguisher. Next slide. Access is a potential competitive advantage that a system can provide. And this slide is a little busy, but looking at Chicago, the third next available, so that's a frequently used metric to a shorthand on figuring out what kind of access is available in Chicago. Overall, like on average, these specialties, it takes 38 days to, any payer to get in for an appointment. Across Cook County, it's a little bit better, so not just Chicago, it's 25 days. And in looking at these same specialties, as for us as a system, we're at about 36 days. So I think we have done a lot of work to improve that number and get that number down. But I think the call to action is to continue to work on that, because that will be a real differentiator in the marketplace.
I have a question. This is an average, right?
The 38 and yes.
And so sometimes it's higher than that, I assume.
Yes.
This is somewhere in the middle.
Right.
And it really impacts people's ability to get specialty care.
Yes.
More so than primary care.
Yes, I would agree with that. Looking at the next slide. So we're seeing a lot of pressure on safety nets. I think of Cook County Health as the safety net, but there's a whole network of safety net providers, all of whom are experiencing staffing challenges, are making decisions on service reductions. We've certainly seen that in the area of labor and delivery, and we expect to see more of that reduction in labor and delivery in particular. Financial instability, dealing with cyber attacks, lawsuits, things like that make it very tough to stay ahead on financially. There's also some potential changes in ownership that could occur, consolidation in the market that could have an impact on these safety nets. Next slide. So quality is critical. It seems to be, we have we've done a great job focusing on quality. Our ratings have improved, and I think we have to continue that work. What distinguishes a health system on quality is also kind of what additional services can be provided that help address disparities, that help address social risk factors, housing, food, etc. And, you know, prioritizing language access and comfort in a location, and expanding patient engagement, and continuing to expand value-based care models. Next slide. This is the last of the 6 areas that we think are real critical to be aware of in the marketplace, and that's the workforce shortages. So it's a national issue. Some systems are responding with more flexible approaches to workforce, and there's a real need to really look at innovation in this area and pipeline programs in order to make sure that you have enough staff to serve your patient base. So with that, we can go to the next slide, and I'll invite Kathy Chan and Letty Close to come up, and Paul Bedeau, I think, is on the line. Once they are complete, Dr. Joshi will come up with the public health perspective. Thank you.
Good morning, I'm Letty Close, Executive Director of Government Affairs, and with me today is Kathy Chan, our Director of Policy. I think most of you know Kathy. Yes. Who you may not be familiar with is Paul Bedeau. He is Cook County's federal lobbyist based in DC, and he's on the line with us. So I'm going to go quickly through just a high-level Medicaid overview, and then I'm going to turn it over to Paul, who will talk about the federal landscape as well as our 2025 priorities. And then Kathy will speak to the state landscape and the 2025 state priorities. So with that, I'm not teaching you anything you don't already know. Many of you are aware federal law sets minimum standards for eligibility and coverage for Medicaid. It is a jointly financed program between the state and the federal government. There is 90% match for Affordable Care Act ACA adults. There is trigger language embedded in Illinois state statute, and that trigger language indicates that if the federal match were to drop below 90%, then Illinois would be required to unwind the expansion for the ACA adults within 90 days. Illinois is one of 9 states that has this trigger language embedded in state statute, and we are in discussions at the state level, as are many individuals in discussions at the state level about how to address this. In state fiscal year 2024, 3.4 million enrollees with comprehensive, in state fiscal year 2024, there were 3.4 million enrollees with comprehensive Medicaid in Illinois. As you all know, Medicaid is critical to the safety net healthcare providers, and it's the largest funder of long-term care services and substance abuse treatment, mental health services. And the majority of Cook County Health patients who have insurance are covered by Medicaid. So with that, I'm going to turn it over to Paul, who's going to walk through the federal aspects of the presentation.
Good morning, Mr. Chairman and Dr. Makaitis, Commissioner Lowry, members of the board. Greetings from our nation's capital. The landscape has changed significantly with the election of President Donald Trump as the 47th president, Vice President Vance. One of the things that has garnered a lot of attention in the news are the president's use of executive orders on day one. I think the important thing for this board to understand is there were a number of health-related executive orders First of all, initiating the process to withdraw from the World Health Organization. This is not an immediate process, but it begins a process and includes like stopping all negotiations with the WHO around pandemic-related issues. This process will be ongoing, something to keep an eye on, especially for public health, as the WHO is a partner with the CDC and with local health departments. The other thing that the president did was to withdraw a number, about 75 of President Biden's executive orders. About 10 or so of those have touched the health policy space. These withdrawals of executive orders are they don't have an immediate effect. They are direction to the agencies, HHS and others, that will, for them to consider and move on making changes around public health, around policy around gender identity and transgender issues, and including Medicaid policy. So we will keep an eye on that as those processes continue over the next weeks and months. The cabinet is starting to take shape as the Senate considers nominations. Next week, we expect Robert F. Kennedy Jr.'s first hearing in the Senate Finance Committee for his nomination to be Secretary of Health and Human Services. There are a number of sub-cabinet appointees that will have subsequent hearings, and we'll keep an eye on that. It's worth noting that the U.S. Supreme Court has a majority of Republican-appointed justices, several of which were appointed by President Trump. So he has a friendly court for any issues coming before the high court. Next slide, please. In terms of the Congress, the House has a Republican majority. The Republicans were able to hold the majority. Mike Johnson of Louisiana was able to maintain his speakership. And currently there are 220 Republicans and 215 Democrats. That number may change as a number of House Republicans have been nominated by President Trump to serve in his administration. So there may be some adjustment, but the bottom line is there's a very narrow majority in the House. So any kind of block of members, particularly in the majority, can have a lot of say in terms of what happens going forward. The minority leader is Hakeem Jeffries of New York. And in the Senate, there is a significant majority for the Republicans, 53 to 47. And as you may be aware, in the Senate, any single member can really have a great influence on the process, because the Senate basically functions on unanimous consent. So any member who chooses to withdraw consent can slow the process. The majority leader is John Thune of Nebraska, and Chuck Schumer continues to be the Democratic leader in the Senate. The agenda in Congress, there are a number of items that are sort of immediate. The first thing that we need to be tracking is the funding bills for fiscal year 2025. We are currently in our second continuing resolution, maintaining funding for the current fiscal year, which started on October 1st. Congress extended that through March, the middle of March. They need to figure that out. And there is also a debt limit that will expire, and they need to address that. And that is being considered for the middle of March as well. And the other thing that's top of mind for the Congress is the 2017 tax cuts that were enacted in the previous Trump administration. Those expire this year, and Congress is committed to extending those. So there will be a major budget reconciliation bill, and that just means it's a major fiscal bill that can be passed with a simple majority. And since Republicans have the House and Senate, that's how they plan to extend those tax cuts. The issue for Cook County Health will be that will also include potential changes to the Medicaid program. There have been a number of proposed cuts to Medicaid that may be used to offset the cost of extending those tax cuts. That could include a cap on funding for the states. That could include reducing the federal match for the Affordable Care Act expansion population, and a number of other reductions that are on the table for Medicaid. So we will need to be watching that very closely. The other thing that is potentially included in the reconciliation bill would be immigration reform, and that also includes significant spending. So it increases the pressure on Medicaid and other federal spending programs in terms of finding offsets. Next slide, please. So with that in mind, we're going to be looking obviously at the top priority for President Preckwinkle's office will be protecting the Medicaid program and avoiding any cuts to the program that would harm the bottom line for the county and for CCH. The other issue that is top of mind is the statutory cuts to the state allocations for the disproportionate share hospital program. That those cuts were delayed in the last couple continuing resolutions, and we are fairly comfortable that they will continue to be delayed. There's bipartisan support for that, but given the fiscal situation and sort of a overall austerity environment on the Hill, we're very concerned and will continue to advocate proactively for delay of those cuts. And then Medicare telehealth flexibilities that were enacted during the pandemic are set to expire. There's broad support to extend those, and we will continue to support that. We will continue to support National Health Service core loan forgiveness for providers who choose to serve in Cook County correctional settings, difficult place to work, and it would be great to make them able to take advantage of the National Health Service Core loan forgiveness program that is available for other health providers. We will continue to work to protect the 340B program, which is so important for our pharmacy members and is currently under a lot of scrutiny, and the pharma industry is looking to make changes to that. And finally, at the end, included in the tax debate will be the extension of the Affordable Care Act marketplace enhanced tax credits that have enabled folks to afford private health insurance on the AC exchanges. And that is my report.
Good morning, directors. Kathy Chan, Director of Policy. I'll provide an overview of the state landscape. So as all of you are probably well aware, we have constitutional officers who are all of the Democratic Party, but notable here related to some of the conversation today around healthcare priorities. We've noted Governor J.B. Pritzker and Attorney General Kwame Raoul as two individuals who we have worked closely with, offices that we work closely with, and expect to continue work closely with in light of the things that we've already heard earlier this week in terms of the executive orders and changes at the federal government level. The 104th General Assembly just was sworn in earlier this month, and based on the results of the November elections, the Democrats continue to hold their supermajority in both chambers. In the House, the Democrats have 78 seats and Republicans have 40 seats. The leadership in the House remains the same. So Speaker Chris Welch remains the Speaker, and Minority Leader Tony McCombie also remains the leader of the Republican House members. In the Senate, the Democrats have 40 seats and the Republicans have 19 seats. Again, both the leaders in the Senate remain the same, with President Don Harmon of the Democrats and then Minority Leader John Curran leading the Republicans. Next slide, please. As the General Assembly begins their session in full swing next week when they return to Springfield, one of the things that we know will be particularly challenging in this state legislative session is a projected budget deficit of over $3.2 billion in fiscal year 2026. This is state fiscal year 2026, which starts on July 1st of 2025. This is the state budget that legislators will have to pass by May 31st, ideally by May 31st. Which only requires a simple majority to pass a state budget by that time. This is really due to just Illinois being in a position of having a structural deficit, just meaning that we as a state do not take in enough revenue to support all of the programs that are in place. This projected budget deficit was announced in November of 2024 and assumes that all of the revenue that is being projected is maintained at the same level. All of the programs and services that are in place are all maintained at the same level. So there's a lot of assumption built into that. Things could certainly change over the next several weeks and months, but that is really the most current information that people are working from right now, which obviously puts Illinois in a very challenging position. When it comes to Medicaid, Medicaid makes up 16% of state general revenue funds. So it is a significant portion of the state budget and the money that the state takes in from revenue. Given the the existing proposals that have already been floated in Congress, we are certainly watching out for what federal policies will mean, given that there are such close ties between state and federal Medicaid programs, particularly the financing piece. That is what is most concerning and the biggest question mark that we'll need to be looking at going into the state legislative session. Additionally, you may also be aware that in July of last year, Illinois received approval for an 1115 Medicaid waiver. This is exciting because it will offer individuals in Medicaid new access to coverage of health-related social needs such as food and housing, as well as reentry support services for the justice involved. While the state received approval last year and has submitted a number of pieces of paperwork and planning documents, this is certainly something that I think we are also keeping our eye on to make sure that this can continue to move forward, and obviously staying in close touch with leaders at the Department of Healthcare and Family Services to ensure that this can continue to move forward under the new federal administration. Of course, Medicaid healthcare providers face ongoing workforce challenges, as you heard earlier from Andrea. Another thing that we are going to be, that the state is going to have to contend with this year is the Health Benefit for Immigrant Adults and Seniors program. This is the Medicaid-like program that was first created in 2020 that provides Medicaid-like services and coverage to immigrant adults and seniors who don't qualify for traditional Medicaid because of their immigration status. And because of that, the state does not receive federal match for most of the services provided in this program. So it provides an additional pressure at the state level that is not tied to the federal government, but because of the financial pressures that Illinois is facing, does present some vulnerabilities potentially for this program. And then last but not least is behavioral health funding and infrastructure. This is obviously a priority for the health system in wanting to make further advances with this, and the state has invested in behavioral health funding and infrastructure, but given, again, the budget challenge, will there be opportunity to build on this momentum? Additional priorities at the state level include, again, making sure that Illinois remains an leader around protecting reproductive health and gender-affirming care. And one thing that Springfield will also be working on is the regional transportation system, which is also looking at needing some additional funds to continue services. And then last but not least is clean energy and climate resilience. So these are all items that will likely be on the docket for legislators with the umbrella of a large budget deficit that they will have to contend with. Next slide, please. When it comes to the state priorities for Cook County Health, we work closely with President Preckwinkle's office and her team to make sure that these priorities of the health system are communicated and reflected in legislation that we take a position on. Our first, second, and third priority is really preserving and protecting Medicaid. We have shared that we would like to see the state unfreeze or reopen the health benefit for immigrant adults and seniors. This is a very important program to our patients. It's an important program to the health system. Obviously, you heard me say about some of the challenges that this program might face given the budget challenges that face Illinois. We'd also like to see the state pursue program simplifications that really make it easier for people in Medicaid to keep their coverage and implement things like continuous eligibility for children through age 5 and presumptive eligibility for adults. These were policies that were promoted under the Biden administration. It's not yet clear what, and the new Trump administration has not taken a position on these yet, but these are good policies, so time will tell whether these will continue to be allowed or whether the state will pursue them. And then last but not least is certainly implement the approved 1115 waiver. Our additional priorities at the state level include increasing state funding to local health departments. This has been an ongoing priority to ensure that Cook County Department of Public Health and other local health departments receive the adequate funding that they need to deliver their public health services. We also want to continue to support legislation kind of in coalition with others that are really leading these efforts that use a harm reduction approach really to decrease opioid deaths and to promote treatment. And then last but not least is efforts, again, in coalition with others to improve behavioral health infrastructure and address gaps in workforce. And next slide, and I believe that's the end of my slide, I will turn it over to Dr. Karen Joshi from Cook County Department of Public Health.
Thank you. There are any initial questions here. I've noticed a lot of information on state and federal. We're getting all the information for now, but just highlight. I just asked if you would like. Okay.
Given the budget deficit, are we looking at the programs to be able to understand if asked, which I would imagine we are, how could we tighten up our belts and still maintain adequate coverage to our constituency?
Well, right now, the governor is scheduled to give his budget address, it's, I think, believe February 19th. It's a Wednesday in February. That will give a much clearer picture as to what the vision is that the governor has for state agencies. At this point, we have not been asked directly about any haircuts that we could take. But I think that's a good point in thinking about where those opportunities might lie. I think the one thing to note is that in Illinois, Medicaid, or Illinois is a state that ranks close to the bottom in terms of per enrollee spending when it comes to kind of how much states spend on Medicaid in general. So while there probably could be belt tightening, you know, in a lot of different places, we're already spending less than many other states in for per enrollee services here in Illinois. So there might be a little bit less wiggle room compared to perhaps where other states are at. But I think that's a good question.
The other thing would be also to show the counter, that if this program is removed, the need for the care doesn't go away. So it's going to create a cost. So if we can present that, then that may be the counter.
Yeah, absolutely. The unique piece about Cook County Health, I mean, there's many unique things about our system, but there's kind of a triple effect on us with any kind of reductions to eligibility or cuts to Medicaid, is that we will potentially lose patients who right now are covered by Medicaid. So we'll lose that revenue source because we're also a plan. We could potentially also lose members, and because we have historically been the provider of care to the uninsured, we would likely see an increase in our costs for uninsured care. So it's really a triple effect that is very unique to our system, that we have been very deliberate in how we message that to elected officials.
And I say, Director Ryder?
Yeah. So I think we're very fortunate in that when it comes to public health and healthcare, that Speaker Welch and Senate President Harmon are in relative close proximity to the system, but also represent areas where we have clinics and provide services themselves as individual elected officials. And the Chicago delegation, and you guys can correct me if I'm wrong, I think would be in an uproar if we were in a position where we were going to get service cuts, especially during this time. The Chicago delegation has a large footprint in the legislature, and represents the largest density of vulnerable populations from both our Black and immigrant communities. And not to say that public health resources and Medicaid and Medicare aren't important tools for folks downstate, because they certainly are, and it doesn't cross over into other populations. But I think we are very fortunate. I know in particular, Speaker Welch has always, been an advocate for, community health and healthcare, and he's actually fought to keep hospitals open in the past. So
He has been. Speaker Welch, President Harmon, and to your point, the Chicago/Cook County delegation have been very supportive of us, both at the state and the federal level. And of course, our biggest champion is President Preckwinkle and the county board.
yeah, absolutely.
We're fortunate, whereas, we talk to our counterparts in New York and LA, and they don't always have the same level of
Yeah,
support.
and I should point that is worth noting. Tony is a very strong champion, and spends, as we all know, Tony spends a lot of time on the health system herself, and takes a lot of pride in all the gains we've made. She's going to fight to protect that.
I just want to call on the directors, Director Ziegler, and then Director Green.
Thank you for the presentation. Can you say more around the request to improve the behavioral health infrastructure and what specific gaps or infrastructure improvements are being targeted with that?
Yeah, so this is really at the recommendation of the Office of Behavioral Health, and some of the priorities that they have outlined when it comes to workforce improvements, certainly ensuring that there are appropriate numbers of providers kind of at all levels, and we don't have specific proposals let me clarify. We're not suggesting any specific legislation at this point. We want to be engaged in any efforts that are happening in Springfield, particularly when it comes to legislation that might be filed. We'd like to ensure that we have an opportunity to voice a position on legislation. And because the legislature is just getting underway and they have bill filing deadlines coming up, we're looking at legislation as it gets filed and then working with our internal subject matter experts to review that and see whether these fit into the priority areas and then taking appropriate positions. So I don't have any specific legislation to share with you at this time, but we're happy to come back and share that once there are proposals for us to be able to weigh in on.
Yeah, I mean, certainly there are infrastructure gaps in the workforce, but in terms of kind of communicating with that office, it would be great to partner with CCH with like a specific list of demands to present at this, not demands, but specific list of requests to kind of guide that work at the state level.
Yeah.
Director Green.
So thank you for this. I did notice both reproductive health and gender affirming care, both very important, considering the environment we're in and our geographical location where Illinois sits in respect of where we are. Is there a reason they're listed together and have those, or in the future, will they be considered separately? 73 slide, number 73?
I think that in some of the legislation, the Reproductive Health Act, they've been kind of addressed together. So that's the reason that they were just included, because sometimes those issues are considered, I guess, sensitive health issues and need additional protection for the patients and the providers. And in the legislation, in previous legislation that's been filed, they have been kind of addressed in the same bill. So that, I think that's the only reason that we included them as a single item there.
But with respect to our organization, we're making sure that we are not addressing it like from financial and political and views together. I say that because of the historical gaps in the care of maternal mortality, infant mortality, when it comes like that. And sometimes when things, and I say this as a person of the LGBT community as a whole, you know, but in my experience, sometimes when those things are grouped together, the efforts for maternal health then become diluted and anemic. And so we don't want that given the gaps in maternal health. So from our perspective, we're always keeping in mind not to kind of put that under an umbrella, correct?
Yeah, and again, Director, this is like information for as we start the strategic plan, which we'll all have like one-on-one input with them overall, right? So just to level set. Two, I think Andrea, I'm sure you're taking notes here on, as part of this, and we're doing scenario analysis. If this happens, if that happens, as part of this overall strategic plan. Is that correct, Andrea? Thank you. Okay. All right. Director Herring.
Yes, again, this is just to provide context, because earlier on, we were talking about immigration and immigrants and being able to provide health care for them, but this is a continuing discussion about the plight that we're in moving forward based upon potential changes that the current administration will make, because it will affect state government. So that means it's going to affect local government. There will be cuts in funding to local government. And so we need to gear up and buckle up or tighten our seat belts, or tighten our belts. So it's going to be around for a while.
Yeah, we should assume that we should assume that is the base case, and that we have to adapt. Yeah.
go on point. If you can go to page 50 of the document. Thought about saying this earlier, but there were a couple comments that make it worthy of going back to, from my perspective. Patient demographics. I think this becomes
Andrea?
very crucial when we start.
Hold
looking
on, we need to bring Andrea up. That was part of her presentation.
Oh.
But you're gonna go to a specific page. That was Andrea. Thank you.
She's
coming.
No,
Please, it's okay. Andrea, we will make time for this. This is important. Thank you.
Okay. I noticed when we made reference to here is in Andrea, in your speech, as well as Kathy, I think you made a reference to, and we said no surprise, the majority is non-white. But that's a framing that can skew a person's mindset to a different perspective. If we look at the numbers show it is very reflective of what we typically think of Chicago. We got 33%, which is basically a third white, 38, which is again close to a 3% African American, and then you got a third of others. You can break it down. The others is 21%. But when we say it is majority non-white, that can skew the perspective. But if we actually state the numbers as they are, then we may be able to get more allies than we think we have. Because when we start saying a third of the participants are white, where do they live? Now, all of a sudden, it may help other people who would not necessarily be on board with what we're saying think differently, because that becomes their constituency, as opposed to them, it becomes us. And it's small, but yet major, because it does shape the perception of the individual who's listening to the words that are being spoken. That's all. I just wanted to point that out, because I heard a couple things, and I thought it was really worth coming back and addressing it.
Yeah, I hear that. I think we can look at these numbers in a lot of different ways, depending on what argument or what audience we have. Yeah, well, point well taken.
But I also think that I think it's a fair characterization to say that it's, majority minority or majority people of color, because our policymakers, as we have them, the people we're going to for funding, despite the national disinvestment in things like diversity, equity, inclusion that's coming out of the current presidential administration, taking care of vulnerable populations and having a significant population of people that have been disproportionately denied access to quality health care and us providing it is important to the people we're actually doing the outreach to. I mean, I'm talking to our leadership down in Springfield about this, 100% on their list, and very important to the Black Caucus and Latino Caucus.
I think also, as you said, Director Robinson, it continues to sadly push a narrative of a non-white or an othering of other groups, when there's, as you said, the largest percentage in this demographic, the second largest percentage is those that are white. And sadly, those that, population, it's not necessarily thought of that those include persons that may be white. And so that vulnerable populations or populations that may be at risk are unfortunately messaged that that's a different group of people than the majority race. And so making sure that we note that, and so that not only local but also rural, that's also other folks that are urban versus folks that are rural, and those needs are frequently the same, but we recognize that the percentage of population is still very similar. Making sure that we recognize that and push and promote that as a narrative, I think, will be very important as well.
And if I could just add on quickly to this conversation, because I had some of the same thoughts and looking at how the population was being characterized. I also would be interested in seeing the income and employment breakout, and additionally a characterization of the most common chronic health conditions. And, that comes to mind as we're kind of loosely using this term vulnerable populations, but I think it's important to consider, like, what are we calling vulnerable? Are we calling vulnerable as it relates to income, trauma exposure, chronic health? What is that? I think from what I gathered from the presentation, vulnerable was based on Medicaid and uninsured status, but I think we should be clear about how we're using that term, and perhaps some other characteristics are
relevant to who we're considering to be vulnerable. Very good point. One of the things I had noted, physical and cognitive accessibility, that could be a vulnerability, as well as LGBTQ and other statuses, especially those that may be at risk now from other political methods as well.
Sectionalities too.
I'm sorry, Director Bott, any questions for Director Bott?
Oh, no,
Awesome.
I think the last two comments were on the thread I was gonna go down, but the intersectionalities and being mindful of intersectionality among these areas is important as we look at the data and think about interventions. And I would suggest, if not already done, what is some of the scenario planning that we need to do for those issues that are to come that will impact, the populations we serve, and the strategies to address that.
Thank you. Any others?
I think probably something that would be instructive, because again, I think this is a nuanced conversation when you're down talking to policymakers in Springfield, is a breakdown of those populations related to their payer status, because I think that's a big difference too. Some people utilize, different populations utilize our services for different things at various points. Just like some folks who are in their, their health insurance wouldn't cover certain prenatal care back in the day. They would go to the public health department to do it because there was a gap in their coverage, but otherwise they had really good health insurance on everything else. So I think understanding that, but there's going to be a huge language and education gap between some of the people Kathy and Letty are talking to in this, and drilling down on that, because everybody who's a policymaker down in Springfield, they care about their community, and you gotta count noses to get things done. And I do think, and I do very much understand the othering of other people, and that's important. As as I fight people on that every day, but I think that if you look at a percentage of population that utilize our services relative to the percentages of people who break down, if you were to look at it, I would, the people's access to private health care and private insurance and, large, big university, research-oriented hospitals, you're gonna see a different demographic skew than what we see with what our population is. And I think we need to embrace that too, because that's important. We occupy a space that the big guns don't necessarily want. And it sort of gets back to one of the criticisms I have of some of our big hospitals, in that what they do to satisfy their 501c3 status or their tax status is they don't go into the community and provide the types of services we do. They throw money at shiny buildings and put on seminars instead of providing direct care.
Thank you. Appreciate the directors. I think all the expertise and experience, as I think about this board, as we thought about the construction and the composition of this board, the expertise and experience comes through. So thank you for your constructive engagement. Thank you, Andrew and Director Josh. Dr. Josh. Well, we got like 6 doctors on
told I
the
have 4
board,
minutes,
please.
so I shall proceed through these slides expeditiously. Welcome to a whirlwind tour of public health.
No, thank you.
Kieran
You
Joshi.
do the necessary. Thank you
so much.
You spent a couple of years just seeing you on a screen.
Yeah, take your time. We're just happy to see.
Remember those
Thank
days?
you. Thank you for the reminder. Kieran Joshi, Interim Chief Operating Officer, Cook County Department of Public Health. I am here this morning to provide a public health perspective as well as a framework for the CCH system-wide strategic planning effort that Andrea is leading. If you go back to the prior slide, I just wanted to start with a framework, wanting to talk a little bit about how public health views the world, the lens through which we do our work. And so if you look at the right-hand side, you'll see the word health inequities in that bright yellow, canary yellow box. Health inequity is just a level set here, are the preventable, avoidable, unjust differences in health outcomes in a population. Some people use the word disparities. We prefer to use the word health inequities. What causes those unjust differences? Well, looking upstream from them are the social determinants of health, which I know all of you must be well aware of. I think the key issue that's driving the differences is a maldistribution of those social determinants. Why is it that those social determinants like access to health care, housing, income, why are they maldistributed? Our understanding based on quite a bit of analysis and data is that it really stems from the structural determinants of health. And so here we think of things like structural racism, harkening back to that prior conversation, that really, I think, deeply thoughtful conversation that just preceded this presentation. I think that term was sort of like kind of percolating there, but no one actually acknowledged it. It's really structural racism, again, that I would argue, and a number of the isms, I'm talking about sexism, ableism, the list goes on, that are driving these differences. I think also included in this large sort of group of factors, these forces that are impacting our populations are societal issues, and I'll speak to what some of those are shortly. Next slide. So in order to make all the myriad of data and information accessible and understandable to you all, we've decided to divide them up into thematic areas. Sorry, I think you went backwards. You want to go forwards 2 slides.
Wrong way.
So we're going to start. I'm going to start out by talking just a little bit about demographic trends. I think Andrea did a really nice job of covering those. Moving on to cross-cutting issues, the social determinants, and then get into sort of subject areas that you all are very familiar with. For each of these areas, we've tried to, after some really robust internal discussion at the health department, identify key strategic issues that you should definitely consider as you move through the strategic planning process, as well as some associated data. Now, because of the time here, I'm going to really just touch on and highlight some of those key strategic issues. More than happy to make myself or my colleagues at the health department available for further discussions and answering any questions that you may have. Next slide. So again, with respect to demographic trends, Andrea, I think, did a really nice job of highlighting the declining population in Cook County and the fact that it's aging. So definitely has some major implications for how Cook County Health as a healthcare provider invests resources. We're also continuing to see a lot of churn and change in the racial and ethnic makeup of Cook County, including increases in Latina people, as well as the Asian population. Next slide. I'm going to skip over these and move on to the cross-cutting issues slides. Again, I highly recommend you take a look at this data and the PDF of the slides at your leisure. There's some really helpful graphs that would supplement the points that I'm making here. So in terms of cross-cutting issues, I think one thing that we really need to consider, because clearly it's an existential issue, is climate change. And we're seeing more and more health systems get involved in sustainability efforts and looking at their operations. And I know we're no exception to that. I think the Joint Commission actually recently began sort of the health system sustainable certification. So that's something that we could definitely explore. We just had a really robust discussion about potential immigration policy changes. And of course, would want to focus on the funding and the uncertainty, the real uncertainty, to use a really mild term, that we are concerned about with public health funding and healthcare funding, specifically related to things like immunization coverage and infectious disease research, which I'll touch on towards the end of this presentation. Coupled with that, there's just a glimmer of hope, perhaps, in terms of some discussion around increasing funding for chronic disease prevention. So we're definitely monitoring that as a health department and exploring ways that we could be well positioned to absorb any funds that may come down. Moving on next to the social determinants of health, I think you all are well aware of some of these issues, so I'm just going to highlight here the things that we're considering on, and wanted to make the point that for a lot of these issues, I'm really proud to say that our health department and its health system are already working to address things like workforce issues, housing issues, and I just want to close out this slide by pointing out the significant increasing housing costs in Cook County across the board. That's something that we definitely need to keep in mind, even as we continue to do good work like supporting the flexible housing pool and supporting other housing initiatives. Moving on now to behavioral health, I think you've heard myself and my colleague, Dr. Nutter, speak to substance use issues and mental health issues. I do want to highlight a couple of top-line things here. First, that there is certainly a little bit more than a glimmer of hope in terms of shifting trends in the opioid overdose epidemic. Nationally, we're seeing a plateau and really a decline in deaths. I think that's definitely cause for some happiness there in terms of deaths averted. But we need to look at these trends very cautiously and with some concern. And the reason for that is that the thing that's driving the decline nationally is a decline in deaths among white people, white adults. We're seeing increases continue among Black adults and Latino adults. Now, in Cook County specifically, we have seen a decline across the board this past year in 2024. With respect to overdose deaths, we do not have data disaggregated by race or ethnicity as yet to comment on the racial and ethnic makeup of that decline. So again, I don't think we can let up here. We need to continue all of our efforts and make sure that we're preventing every death possible. Also wanted to touch on here some emerging trends in terms of increasing morbidity and mortality from alcohol, and of course, marijuana use, which is increasing among youth in particular. So definitely cause for concern. Next slide. Next slide. Moving on to mental health. Again, you've heard us talk about this several times. I do want to highlight ongoing issues with access, ongoing and increasing issues among suicide, most troubling among youth and young adults. This is definitely a space in which our health department and I think the Office of Behavioral Health needs to engage and continue working. This correlates with a national trend of decreasing social engagement, increasing loneliness. And these trends have been highlighted by recent Surgeon General's reports, so they're definitely on the radar of public health. And I think, again, we need to think about how we structure our strategies to address some of these drivers. Next slide. And moving on to maternal and child health. Again, I think all of you are well aware of some of the issues with respect to maternal mortality in particular, which I view as a scourge. We know that according to CDC, 80% of pregnancy-related deaths are preventable. In 2022, infants born to Black women were more than twice as likely to die as those born to white women. And I want to highlight here the model and the framework that I referenced earlier in terms of the drivers here being really structural issues, inequities related to discrimination and social economic factors. Of course, we also do think about individual level risk factors as well and try to address those in our practice.
and really proud to work in an institution that takes these issues to heart. Thank you. And then moving on to chronic diseases, this is an area of work that we're really hoping to strengthen in CCDPH over the coming years. We have a long history of working on these issues with a so-called policy systems and environment approach. This has sort of been characterized as something new for public health, when in fact it's something that public health has been doing for decades, if not centuries, and really trying to think about upstream ways to approach chronic disease prevention. So think about, rather than doing one-on-one tobacco cessation classes, looking to pass legislation like Tobacco 21, which has successfully increased the age at which people smoke are able to purchase tobacco products. Also doing a lot of work in the food space to address this issue of food insecurity, specifically in Black and brown communities. I know the health system overall as a care provider has done a lot of work in this space as well. And then moving on to communicable diseases, which in many ways is one of our core functions. We're very concerned about decreases in vaccination rates, both nationally and locally. If you dig into the data, you're seeing increasing rates of exemptions, largely religious exemptions. And we think that's a key driver, along with the significant amount of vaccine misinformation and disinformation that's being generated in the social media space. I think there's been a lot of discussion in public health post-pandemic, thinking about what we need to do differently. And it's very clear that we need to be ready for large-scale outbreaks, potential pandemics, and these so-called high-consequence infectious diseases. We at the health department have spent a lot of time strengthening our public health emergency preparedness unit planning, and we hope to also continue exercising. I think somebody mentioned the importance of exercising and drilling earlier. I think that's definitely key. STIs, I want to make mention of the increase specifically in congenital syphilis cases. We've done some work highlighting this, as well as developing communications campaigns to address it. And then, of course, this decades-long issue of an increase in drug-resistant organisms, which our health department has been partnering with local healthcare providers to address. Just moving on here, and going to close out with injuries and violence. One thing I wanted to highlight certainly is the significant increase in car crash fatalities, which increased 52% between 2018 and 2022. There's a significant inequity here in terms of the people that are dying from these car crashes and experiencing these injuries. And I think it's just an example of this ongoing trend that I've been trying to highlight as a through line throughout this presentation. In terms of violence, I think I'm pleased that we're sort of starting to see a plateau in homicides county-wide, but of course, this remains a terrible scourge, and I think I know my colleagues throughout Cook County government, and particularly at the Justice Advisory Council, are doing significant work to address this. Another sort of element and component of violence is violence that's associated with law enforcement contact. This remains an issue, and I think it's a public health issue, certainly of concern, that needs to continue to be emphasized and addressed. And finally, I just want to close out this whirlwind tour here by summarizing. It's, I think, a significant understatement to say that we face a dynamic environment with a myriad of opportunities and threats. Certainly the health inequities, which I know many of you are familiar with and aware of, remain. And I do think that as a health department, as a care provider, as an insurer, we are positioned to respond effectively if we can make strategic investments, considering all the factors that and the data and the information that have been presented here today. And finally, wanted to close out by saying this is really just sort of like a taste of going to see in the future from CCDPH with respect to community health improvement assessment and planning. Doing community health assessment and planning is a core public health function that we're required to do by law and in order to maintain our accreditation. We do that every 5 years. We're on track to conduct our most recent effort this year, and I expect to come back to you approximately a year from now, hopefully earlier, but at the latest a year from now, to present those assessment findings and our community health improvement plan. So very much looking forward to that. Thank you so much for your time.
Okay, now take a breath. We got a lot of information in. I'm sure a number of our directors have questions, comments, dialogue.
Two very brief comments. With regard to the suicide rates under the mental health slide, I note that the AAMC citation is quoted here, and I know that the city has also put out data with regard to increase in suicide rates among Black youth specifically, and so it would be great to also see that data specific to the county if it's available. And then with regard to maternal health, in your comments, you mentioned the role of discrimination, and of course, we know many of the drivers related to the disparities in maternal health outcomes, particularly in Black women. And I just as a note, I think that conversation, and I'm not saying that you did this, but that conversation is often framed as disparities related to the birth experiences of lower income Black women. However, those disparities are seen across the economic spectrum of Black women. And so I just want to kind of name that and raise that to the conversation for future discussion.
Yeah, thank you so much for acknowledging that. For those in the room, there's a large body of work, some of it out of the University of Michigan. The name of the researcher escapes me in this moment, that supports that very point. So thank you for lifting that.
Director Sorrell, and then Director Green.
Thank you for this information. How frequently will we be reviewing any strategic goals or targets? Particularly, you mentioned food insecurity. Sadly, a ramification of immigration changes will be problems with not only harvesting our food, but then also getting it to those that are in need. So there are anticipated shortages we're seeing already in California and Arizona from not only eggs, but then now vegetables and crops. Will we be able to more frequently assess what the need is for those in the community to be able to provide particularly those types of groceries that will be certainly in short supply fairly quickly?
Sure. So the streams of data with respect to, I think what you're talking about, flow largely through agriculture departments, so like USDA and I believe Illinois Ag. I'm only familiar with this because there have been some concerns recently related to high-path avian influenza. So we don't specifically have access to that data. In terms of what we provide, much of our data comes from the state, and so we can only analyze what we get from our colleagues at the state, and they typically provide that on an annual basis, and so there's a delay in what we see.
What might be potential indicators that you're utilizing to assess what will be the food needs for those that are constituents that we're serving, so that if there's a way that we need to either kind of shift our vectors to be able to provide for those lacks that we're seeing, how are we able to assess those more adequately?
So thanks to the health system and Cook County government and the president's office, we've been funded to do a biannual behavioral risk factor surveillance system survey. And that survey is a population-based survey in which a vendor will essentially make phone calls to a sample of individuals across suburban Cook County to ask questions about various issues. Food insecurity is one of those issues, and so when we get that survey data back, I'm more than happy to share that with this board. We do also make all of our data available on our health atlas. I think the website is cookcountyhealthatlas.org. It's a wonderful resource. This isn't just a shameless plug. We really want people to use and look at this data. It's only as useful as, you know, the people that use it make it. And so really wanted to encourage everyone to use that.
And is there a community advisory group that can provide along with, and that's excellent for those ongoing surveys and calls in the community, but can provide some of that more on immediate feedback for you to be able to
Absolutely.
make changes?
Yeah, so we're always looking for feedback, and would welcome your feedback into that survey process. I think more broadly, we have a steering committee composed of folks from the community and community partners, as well as representation from Cook County Health, that helps guide our overall community health assessment and improvement planning process. So more on that to follow. Thank you for your question.
Director.
So quickly, I do want to again highlight that, and common practice, right? Maternal health is grouped in with something else.
Yeah.
I do want to also thank Director Ziegler for bringing up the disparities amongst Black maternal health. So while we're getting ready to look at the strategic plan, I want to highlight the opportunity to de-umbrella it from affirming care or child health and things like that, and just really be intentional about our focus before we even start. That way we're not surprised by current outcomes and trying to undo it on the other end.
Any additional, Director Bott or my Western Cross or Director Lowry, I want to make sure I acknowledge you, give you a chance to comment or question.
Thank you. I appreciate Dr. Joshi's comments in the thread of conversation. I think what I was going to ask has been covered, but know that Dr. Joshi, happy to help and contribute where you need it.
Thank you. Directors, I'll highlight that there is, Dr. Joshi put together a very, very comprehensive package when you get a chance to review it. He went over some slides, but there's a lot of detail there as we're preparing. And so to you and the staff and team, thank you for this early preparation. And we look forward to working with you through this process.
Thank you, Chair. Thank you, Directors.
Thank you.
All right.
Dr. McKay,
Sure.
comment?
Absolutely. Well, thank you again to our team. Thanks, Dr. Joshi. Thanks to our policy team, Kathy, Letty, Paul. I don't know if you're still on. And thank you, Andrea, for pulling all of this together. Very robust discussion. I appreciate the extra time, Chair Taylor. And thank you, directors, for a really engaging discussion. I do want to kind of call us back to mission and vision, right? That should be the guiding principles of all of this discussion, right? Especially as we start putting kind of the tactics in place in the strategic plan in the coming months, right? So in terms of the mission, right, we're establishing universal access to the world's best care and health services, right, regardless of ability to pay, so that everyone can live their healthiest life. And I think put more succinctly in the vision statement, right, is to ensure that health is a human right. So, okay, so thank you again, and we look forward to the ongoing discussion.
Thank you very much, appreciate it. Also, just I thought about this, slides 101 and 102, when you get a chance, directors, reviewing, the team put together a good SWOT analysis at both federal and state. To think about it, just a kind of a summary. I know there was a lot of data, but how we think about from a strategic perspective. Thank you. Due to the time constraints, which we talked about, the last two informational items on the agenda will not be reviewed today, but they will be included in the meeting record. That's the December financial report will be reviewed, and the December financial report will be reviewed at the February 7th Finance Committee meeting, and the HR metrics will be wrapped into the report for the HR committee meeting that's also being held on February 7th. So you're going to have a full agenda. That's what we use. I think that is it for us today. I really, really appreciate it. Again, thanks to all the staff and directors, just the level set for the next year. We're going to be in the middle of our strategic planning process. And so we're going to keep to the schedule, right, that Andrea laid out for us. If you look at the schedule of items, we're going to follow up on each time. So we're going to keep to that schedule, and we'll allow as much time needed to actually get the work done that we need to get done, and to receive the information we need to receive. Okay? That's it. I don't think we're going into closed session today. Thank you. The board is not going into closed session. So if there are no other questions or matters to discuss, we can move to adjourn the meeting. Do I have a motion to adjourn the meeting? So moved.
Second.
Thank you. The motion to adjourn has been made and seconded. Is there any discussion on the motion?
It's not debatable.
Not a debatable motion? Well, there might be. There might be, you know. Someone's going to say here. All in favor? Aye. All opposed? Thank you. Hearing none, the ayes have it. The motion is, the meeting is adjourned.